Hello and welcome back. I'll be discussing an imaging in the diagnosis of acute mesenteric ischemia, intestinal inflammatory disorders, and intestinal obstruction. So this will be in continuation to part 2.2. The talk is going to concentrate very heavily on the imaging findings, and will rely very prominently on understanding the pretest probabilities of intestinal obstruction versus acute mesenteric ischemia, which I discussed in part 2.2. So before you delve into this, I would strongly suggest that you review that if you've not got done so already. So getting into it, in today's lecture, I'll be talking about one. We'll review the radiological anatomy of the gastrointestinal tract as seen on CT imaging. We'll describe the imaging appearance of quote unquote true intestinal obstruction. We'll deduce the clinical situations in which a patient with suspected intestinal obstruction requires attention from internal medicine or clinical immunology and rheumatology. Using distribution of wall thickness, we'll try to determine the possibility of intestinal wall ischemia or vasculitis as a possible, etiology of bowel wall thickening. We'll try to find, we'll describe other imaging findings that might suggest intestinal ischemia as a possible, underlying cause. Uh, Under this, we'll be talking about specifically mural stratification, the quote unquote comb sign, and we'll be talking about pneumatosis intestinalis. Then finally, we'll try to differentiate Crohn's disease from acute mesenteric ischemia based on the progressive changes in the bowel wall morphology that you normally get in these two entities. So coming to the normal intestinal morphology on CT imaging. Now, okay. So schematically speaking, there are two parts of the gastrointestinal tract. We've got an intraperitoneal part, which is extending into the peritoneal cavity, and we've got the retroperitoneal part. So after the stomach, we have the first part of the duodenum, which on a coronal image. So coronal image would be an image passing like this. Okay, so perpendicular to the sagittal or mid-sagittal plane. Uh, Now, this image is the best, at least for a novice, at reading radiological images, because it shows you the exact distribution of the various parts of the GI tract. So, as you can see here, we've got the stomach, and then the stomach is extending into the first part of the duodenum, which is also called the bulb of the duodenum. Okay. After the first part of the duodenum, naturally, we have the second part of the duodenum and the third part of the duodenum. So those are both retroperitoneal, and I have highlighted them here. These are the first, this is the second, and that is the third part of the duodenum. Then the third part of the duodenum extends into the fourth part of the duodenum, and this is the fourth portion, and that then becomes intraperitoneal, as you can see. So the first and fourth parts are intraperitoneal, whereas the second and third parts are retroperitoneal. And that the connection of the mesentery at this point is what we call the ligament of treats. So that is the next thing, but it is not easily visible on imaging. Now, after the ligament of treats, everything becomes is going to continue to be intraperitoneal. So we've got the jejunum, the ileum, followed by the ileocecal valve, then the cecum, the ascending colon. Now, the transverse colon is the only part of the large intestine that is actually intraperitoneal. Then we've got our descending colon, and finally we've got our rectum. Okay, so this is the gastrointestinal tract starting from the pylorus of the stomach right till the rectum. Okay, so of this, the first and fourth parts of the duodenum, the jejunum and ileum, and the transverse colon are what are intraperitoneal. Now, I've also highlighted, or I've used the level of brightness of the particular word. It corresponds to the level of enhancement that you get in these particular loops of intestine. So the first and fourth parts of the duodenum are not, they enhance in at an intermediate level. The jejunum usually is enhances very briskly. The ileum not as much, and the transverse colon again not as much. This is primarily because the jejunum is the primary site of reabsorption or absorption of most digested material. So that is where most of the blood supply goes. The arterial blood supply to the intestine goes. Okay. Now again using coronal images, you can see that the in a coronal image towards the left of the patient and the upper part of the abdomen, you have the jejunal loops. These are the jejunal loops. And towards the right and lower half of the abdomen, you've got the ileal loops. Now, notably, jejunal loops are noticeably thicker. Okay. Now, an important thing that one needs to understand is jejunal loops or any loop of intestines, thickness should only be mentioned if in a distended segment. So the loop should not have been collapsed. So there should be some fluid inside the lumen of the fluid or air within the lumen of the intestinal segment. Now you can also see the branches of the superior mesenteric artery in this particular case, supplying the jejunum here, and you can also see some of the branches of the ileocolic branch of the superior mesenteric artery supplying the ileum there. And then the ileum is extending via the ileocecal valve into the colon. Okay. Now let's talk about how imaging plays a very central role in the diagnosis of true intestinal obstruction. Now, the characteristic feature of true intestinal obstruction is actually the transition point. So, the transition point is actually the point where the obstruction has occurred. So, proximal to that, the bowel loops dilate because they're not able to push material distally across the transition point. So, a dilated loop by definition is said to be more than 3 centimeters in diameter. Now, some people use cutoffs of 2.5 centimeters, which obviously would be more sensitive, but the general dictum is more than 3 centimeters. Now, distally, you get decompressed bowel. That is essentially devoid of any fluid or air. Okay. And the transition point, as we've discussed in the previous lecture, could be formed due to an extrinsic compression. It could be due to a problem with the wall of the intestine. It could be problem with the luminal contents. Now, in luminal contents, we had talked about gallstone, ileus, and I had described in brief regarding Mirizi syndrome, that is compression of the common bile duct by a gallstone within the cystic duct, and that can that can erode into the lumen of the gastrointestinal tract and then distally go and get stuck at the ileocecal valve, causing a gallstone ileus. Now, again, there are other things that also can get stuck, for example, a buzzer or any other kind of foreign body. But again, that is not something that as an internal medicine doctor, deal with on a routine basis. What I want to highlight is one is adhesions, and adhesions obviously occur most commonly post-operatively, and these are by far the most common cause of intestinal obstruction. But after adhesions have been ruled out and hernias have been ruled out, the conditions that I become involved with are inflammatory disorders and neoplastic disorders that either affect the bowel from outside in or primarily affect the bowel wall. So that is where we'll be trying to target our discussion. I'll not be talking too much in detail about neoplastic disorders because they require further assessment, and we need to discuss the pathogenesis and all of these neoplastic disorders of the gastrointestinal tract separately. So that will maybe be an appendix video in this series, but we'll talk about the inflammatory disorders and acute mesenteric ischemia. Now, see, transition point is present in 63 to 93% cases of actual intestinal obstruction. So in this particular uh, cross-sectional image, what you see are the arrow points towards the dilated loops of intestine. So why do I say that it's dilated? Because it's full of fluid. So I can talk about it, and the diameter is more than 3 centimeter. Okay, so that is why it is a dilated loop. Now again, the arrow head points towards loops that are not dilated. So see, as you can see here, the loops here are not dilated. So obviously between this point and this point in the intestinal lumen, there is a transition point. So we run the bowel and then we are able to say that that is exactly where the transition has occurred, or the obstruction has occurred. Now, it's not very obvious where the transition point is in this particular image. So we'll look at another image. So this is a coronal image, again highlighting how coronal images are very useful while trying to localize the transition point and essentially to look at any bowel wall pathology or wall pathology. So as you can see, these are dilated loops, okay, and these dilated loops extend towards a section here, after which the loops are no longer dilated. So actually there is a herniation via this small opening there. So what is that opening? A loop of small intestine has gone through the pelvic bone, and obviously that is the obturator foramen. So this obturator foramen is obviously, or the obturator canal is formed by the obturator internus and obturator externus muscles, making this a internal hernia, specifically an obturator hernia. Okay. So this is a small intestinal obstruction due to an obturator hernia. Now, again, as an internal medicine doctor and as a clinical immunology rheumatologist, I don't really deal with this. Okay, this is something that a radiologist will diagnose in the emergency and refer to a surgery, depending on the need for surgery. So, where do we get involved? Where does internal medicine get involved? So, see, the thing is that things like this, which form the bulk of intestinal obstructions, are never going to be referred to us. So, what does get referred? We'll go into details about that. Okay. So, let's go there with that. So, when internist gets involved in the following situations. Okay, I'll talk about the clinical symptoms, obviously, as usual in this sequence, that is onset, progression, duration, site, radiation, severity, character, aggravating features, relieving features, and associated with features. So, the first situation is abdominal pain. Now, the first patient has acute onset, persistent, intermittently worsening abdominal pain that has started maybe a few hours back or up to a few days back. The pain is focal, it's well localized to the periumbilical region, or in okay, to a little bit to the lower abdomen, more than in some cases poorly localized. It's moderate to severe in intensity. It's colicky in character. Some patients might say it's bloating or as abdominal distension. Sometimes they're not able to characterize it properly. It is aggravated by eating. It is relieved by fasting, but it still persists even if when there is fasting. And it is associated with vomiting or increased fecal frequency, fecal urgency, or fecal incontinence, which has then progressed to full-fledged obstipation. That is, the patient is not even passing gas. So the increased intestinal motility initially, and then there was a progressive decrease in intestinal motility. Now, the second situation is again abdominal pain, which is acute to slightly subacute in onset, but persistent. So, at over hours to a few days. Uh, the okay, so the pain is mild to moderate in nature. The site obviously is diffuse. Okay, uh, not this. So the site is diffuse. Okay, or it is poorly localized but very significant. Okay. Then the pain is has a bloating character, but it's not particularly colicky. It is again aggravated by eating. It is relieved by correction of incidentally detected hypokalemia, hypercalcemia, hypothyroidism, or relief of pain or treatment of whatever was the primary cause of the pain. And vomiting is not really associated, although it may have preceded the development of symptoms because vomiting causes hypokalemia. So that is how it would be associated. So obviously, if you've seen my previous lecture in this series, the first situation we are talking about acute mesenteric, or we are suspecting acute mesenteric ischemia, and we're suspecting small intestinal obstruction. But see, the patient has been referred to us to an internal medicine doctor because the radiology is sure it's not due to herniation of bowel, and there is no intraluminal obstruction. That is, there is no gallstone ileus, there is no bazaar, nothing. So they know it's not that. That's why the patient has been referred to us. Okay. Now I could reframe that and say that the patient has got a either got acute mesenteric ischemia or the patient has got a small intestinal obstruction due to either a inflammatory or a neoplastic change within the bowel wall primarily, or an inflammatory or a or a neoplastic disorder infiltrating into the bowel from outside in. So this is how I could reframe it. Now, on the other hand, situation two would be naturally intestinal pseudo obstruction, and we've already discussed how to evaluate intestinal pseudo obstruction. So we would evaluate it as in we'd look for hyperkalemia, we'd look for hypothyroidism, we'd look for hypercalcemia. We think about central nervous system disorders which would alter neural input into the gastrointestinal tract, or we could primarily also think about increased sympathetic tone and or decreased parasympathetic tone. So, however, this present discussion is going to primarily is going to discuss is going to focus primarily on the need for imaging to differentiate between these two disorders. So with that orientation out of the way, we'll proceed. Okay, so basically this is the topic of this particular lecture. Now, so using imaging in the differentiation of acute mesenteric ischemia versus small intestinal obstruction secondary to either a neoplastic or an inflammatory etiology. So what happens is you have a patient with that situation one type of history, and that patient has on imaging a thickened intestinal wall that is enhancing less than normal. Okay, so we expect that amount, that part of the intestine to enhance a certain amount. So like I said, jejunum would enhance a lot, ileum would be intermediate, but it's enhancing less than surrounding corresponding bowel. Okay, so notably here, one should not compare the ileum to the jejunum because the ileum will always enhance less than the jejunum. Okay. Now, however, if you find that a portion of the ileum is enhancing less than the rest of the ileum, then that obviously means that the blood supply to that part of the jejunum is decreased. So that is almost like, pathognomic. You know it is vasculitis. But this finding is usually not present. It's not even often. It's usually not present. Okay. And this is particularly the case if the culprit, the ischemia is resultant is caused by vasculitis, which is what I deal with most of all. So therefore, in most cases that such cases that get referred to internal medicine, the most common, most relevant finding ends up being the length and distribution of the thickened wall. What part of the bowel wall is thickened and how much of it, what is the length of it that is thickened. So what I do is I essentially use this disease distribution to differentiate between in most cases. So I have made a table in which I have segment of intestinal bowel involved. So small intestinal involved. So small intestinal involvement again naturally could be ileal only, or it could be involvement of non-ileal segments. That is, the jejunum or the duodenum is affected. Okay. Second thing is there could be involvement of a short segment of the bowel. Now, a short segment of the bowel is considered less than 5 centimeters of involvement. Contiguous involvement is considered short segment, or there could be long segment that is more than 10 centimeters of bowel is affected. Okay. Now, if you have ileal involvement and it is short segment, it's almost definitely Crohn's disease. So in that situation, you know you're dealing with Crohn's disease and there's no other differential essentially. There is a very remote possibility of the ileocolic, vessel getting affected by vasculitis. But then again, are other loops not affected? Why is the jejunum that has got a much better blood supply not affected? Becomes a question that you need to that ends up requiring, definite answering. Now, on the other hand, if you have a short segment involved, but it is involving the duodenum or the jejunum, most importantly the jejunum, because the jejunum has the most extensive blood supply. Uh, then again, it could be Crohn's disease because it's still short segment, but it could also be acute mesenteric ischemia. Now, acute mesenteric ischemia, as we've discussed in the previous lecture, part 2.2, could be embolic or could be vasculitic. Thrombotic would affect the vessel very proximally, so it would cause long segment involvement. So it's unlikely to be thrombotic, but it still could be embolic or vasculitic acute mesenteric ischemia. Now, on the other hand, if you have a long segment involvement, just epidemiologically speaking, the most common cause of long segment thickening is infection. particularly if the ileum is affected. So that's why ileum. Now, as we'll discuss later in our series on immunology, the Peyer's patches and most of the mucosal associated lymphoid tissues within the gastrointestinal tract are located in the ileum. So infections tend to start there. Now, whereas acute mesenteric ischemia, particularly thrombotic, say SMA thrombosis, could affect the ileum, and there would be a long segment involvement of the ileum. It could then also affect the jejunum, so there will be a long segment involvement. Now, finally, we have ileum involvement of the jejunum and or ileum or non-ileal parts of the GI gastrointestinal tract by a long segment involvement. That is more than 10 centimeters of the bowel, contiguous bowel are thickened. So in that situation, acute mesenteric ischemia becomes a major consideration. So acute mesenteric ischemia in this situation would be more likely to be thrombotic than vasculitic, but vasculitic would be a possibility, and vasculitic specifically we would be considering large vessel vasculitis. So this is the table that I use. So almost in this situation, there's nothing much to think about. It's Crohn's disease. Okay. In every other case, vasculitis is a possibility. However, when it is short segment or acute mesenteric ischemia is a possibility. However, when it's short segment involvement, we are thinking more along the lines of small to medium vessel vasculitis. Whereas when it is long segment involvement, we're thinking about thrombosis, but naturally a thrombosis will be visible within the proximal wall of the proximal lumen of the smaller superior mesenteric artery more than vasculitic disorders. Okay. So after this, if the length of the segment involved is extremely short, that is, it is less than 5 centimeters, then we need to consider a neoplastic etiology. So that would be GI adenocarcinoma more than other GI malignancies, just purely based on the epidemiology of presentation. However, lymphomas are also possible. Lymphomas, as we'll discuss later, are much more bulky and infiltrative and cause a lot of mesenteric lymphadenopathy, very bulky mesenteric lymphadenopathy. Again, the radiologist would pick it up quite, uh, early, bunch before it comes to your attention. Now, in this particular coronal image, what sections of the bowel are thickened? So naturally, it's in the uh, it's in the right side and the lower half of the abdomen. So these are naturally ileal loops. Now, ileal loops are affected in a long segment. So it is long segment involvement and ileal loop involvement. So we would think infection or acute mesenteric ischemia. Okay. Now we could also think of long segment involvement, and there was actually colonic involvement also, and a little bit of jejunal involvement. So in that situation, I would say non-ileal involvement, but long segment. So I would think of a thrombotic acute mesenteric ischemia much more than large vessel vasculitis, just because of epidemiology. So these will be the two conditions. Now in that previous image, the parts of the jejunum and the colon were also affected. So I would go more with this. Okay, so that's how you use this table, and that is the final assessment of the image. Now, there are some other factors that a lot is talked about them whenever, especially internal medicine rounds are done, and we talk about imaging findings and suspect vasculitis or inflammatory disorders. Uh, these at times, but not routinely, can be relevant, and at times they help us narrow down the differential diagnosis, but this is not always the case. Okay, and we need to understand what they signify very clearly. Otherwise, we'll get confused. So this includes three things. One is mural stratification, also called the target sign. Second is comb sign. The third is pneumatosis within the intestinal wall, called pneumatosis intestinalis. Now, this gas can then also extend into the portal veins and or hepatic veins. So we'll discuss exactly what that implies. Now, coming to the first topic, that is the target sign, that is mural stratification as a clue to mesenteric ischemia. Now, the thing is, this is a normal wall. This is the normal wall enhancement. You can see the serosa and the serosa here. Rather, okay, the serosa here and the mucosa here are not separately visible. However, what ends up happening is in neural stratification, you have a apparent hyper enhancement of the submucosal of the serosal and sub the mucosal walls. So you got a white line here and you got a white line inside. Okay, and in between you have got relatively hypointense lesion. So why does this happen? This happens because there is edema here, and that edema essentially compresses the blood vessels there, decreasing the amount of enhancement that occurs when you give contrast to the patient. So this is called neural certification. Now, this is actually called the water density target site. Okay, because the density here is that of water. Now, water has a density of around 30 to 40 Hounsfield units. So that is the density. If you put a region of interest there, you'll see that the attenuation is actually 30 to 40 HU. Okay. Now, this is only an indicative of what? Submucosal edema. It doesn't mean it's vasculitis. Okay, so edema could happen due to capillary leak due to anything. It could happen due to angioedema. It could happen due to inflammation related capillary leak. It could be related to your submucosal vasculitis related vessel inflammation, luminal inflammation, and then secondary capillary leak. So it could be all three. So coming back to the image that we had started our what we just seen earlier. So again, like I said, parts of the jejunum were affected. A lot of the ileum was affected, and it was almost extending into the colon, possibly also. These are that was why we had seen that there was a possibility of acute mesenteric ischemia. Now here we've got neural stratification very clearly visible in some places. Okay, so these are the loops that were clearly neural stratification. Now, what does that mean? The highlighted lobes show mural stratification, but specifically they show attenuation that is similar to water. Okay, and actually, if you know what you're looking at, you'll also see that the mesentery here appears to have appears to be slightly more white as compared to the normal mesentery here. Okay, so the normal mesentery contains a lot of fat but no water. So because of that, fat being darker than water has got this attenuation. This mesentery appears edematous. There's a lot of inflammatory fluid there. And the attenuation of the wall in those lumen, in for example, in this particular stratified lumen of the intestine, is similar to that in the mesentery because both of them contain water. So this is what we call the water density sign, target sign. Now, the water density sign uh, are not exactly, it's not exactly therefore pathognomic of vascular of mesenteric ischemia. It is actually pathognomic of inflammation of the bowel wall. Now, that inflammation could be secondary to an infection, it could be secondary to angioedema or capillary leak rather into the bowel wall. So, that capillary leak could be due to an infection, it could result in inflammation, it could be some non infectious inflammatory etiology, it could be angioedema, it could be ischemic ischemia also. So, it doesn't really narrow things down. Now, another important thing is you can see in some of the relatively proximal bowel you see air bubbles within the lumen of the small intestine. This is not normally present. So you see it here, you see it here, you see it here. This has the appearance of normal feces in the large bowel, the colon. So that is called the small bowel feces sign. It indicates intestinal obstruction. So it happens in those loops that are dilated proximal to the site of transition. But here the obstruction is involving a very large segment of the intestine. So in the loops proximal to that, you have the small bowel feces sign. Okay. Now, from the water density target sign, we'll go ahead and we'll understand what are the other types of target sign. Okay, so the water density target sign is not the only finding that may be present in patients with intestinal inflammation or ischemia. There may be other imaging findings as well. So there are four. The water density target sign, as you can see, is a submucosal edema due to capillary leak causing apparent inner wall and serosal enhancement with in a thickened bowel wall. So that we've understood. Now, the second is the fat density target sign. So here, when you put a region of interest into the wall of the apparently stratified thickened bowel, what you find is that the attenuation is actually that of fat. So this is actually the infiltration of the submucosa with fat. and not water. Okay, so this is called the fat density target sign. Then we have a diffusely hyper enhancing bowel wall. So now the normal jejunum looks like this under normal circumstances. So typically we see this only in the ileum, or we are able to describe this only in the ileum or the duodenum or the colon. Okay, so this is bowel hyperenhancement. This means there is transmural inflammation causing inflammation related vasodilation. So when you give contrast, a lot of contrast goes into the submucosal wall, and there is not enough submucosal edema to cause blanching of those blood vessels. Now finally we have a normally enhancing bowel wall. So this is normal enhancement. So normal enhancement typically occurs when there is transmural or infiltration of the bowel wall by material that has attenuation similar to that of the normal bowel. So what do we suspect in each one of these conditions? In case of the water density target sign, we would think this could be due to, as we've discussed, acute inflammation, which could be due to an infection or may not be due to an infection. It could be due to acute mesenteric ischemia, as we've seen, but it is not directly exactly acute mesenteric ischemia. Okay. Then finally, it could also be due to back pressure because of portal hypertension. Okay. So when you have a water density target sign, these are the three possible entities that you must consider. It is not directly, indicative of mesenteric ischemia, as is often misunderstood. Now, in case of fat intensity target sign, what that means is basically there is either chronic inflammation with metaplasia of cells into fat cells, or there is celiac disease, again resulting in chronic immune activation there, or the patient is just obese, so there's fat deposition there, or in patients who receive chemotherapy, there are post chemotherapy changes, related changes there. Now, hyper enhancement of the bowel wall could be again due to acute inflammation. It could be due to acute mesenteric ischemia, particularly shock related. Okay, that is non-occlusive acute mesenteric ischemia. So as you can see, essentially the water target sign and the hyper enhancement, diffuse hyper enhancement of thickened bowel have essentially very similar differentials, excluding portal hypertension. Now, the normal enhancement doesn't really mean anything. It could be normal, it could be that there is thickening. So we would need to evaluate that further, and we'll talk about that when we talk about neoplasias of the small intestine. So now, importantly, another important thing is blood has got higher attenuation than normal water. So hyperenhancement could also be due to bleeding into the wall of the intestine. But again, bleeding it would not be diffuse, so it would not involve all of the intestinal wall. It would involve a portion of the intestinal wall. So that would be a hematoma within a portion of the intestinal wall. Okay. Now, in that situation, we would obviously evaluate the patient for coagulopathy. Okay. Now, normal enhancement could be a neoplastic infiltration. It could be, acute inflammation that is not severe enough. Uh, and it could also be acute mesenteric ischemia. So what it means is that basically the only time I say that the wall thickening cannot be due to mesenteric ischemia is when you have a fat density target sign. Well, otherwise, whether it is mural stratification with a water density target sign, or there is mural thickening with diffuse enhancement, hyper enhancement, or mural thickening with normal enhancement, it could still be due to acute mesenteric ischemia or acute bowel inflammation. Okay. Now, therefore, mural stratification, yeah. So now, importantly, mural stratification can coexist with normal enhancement, and the jejunal loops here are actually look hyper enhancing. But like I said, normal jejunal loops can also do have a hyper enhancement to them. So that is not something that is specific. Okay. So what we can say is, if you get a fat density target sign, okay, then one can quite clearly say that the intestinal wall thickening is not due to attributable to acute mesenteric ischemia. Okay, that is the only time I can say it is not due to acute mesenteric ischemia. Otherwise, any wall thickening, whether it is showing a water density target sign, or it is showing diffuse hyperenhancement of the bowel wall, or it is showing no significant changes in enhancement, could be due to acute mesenteric ischemia. This is why the patient's history becomes very, very relevant. Okay, because as we've discussed, in case of Crohn's disease, the history is not likely to be that of intestinal obstruction very commonly. Whereas, like I said, intestinal mesenteric ischemia routinely presents with that the situation one history that we just discussed. Okay. Now, another interesting thing is that often the water density target sign and diffuse wall enhancement can occur simultaneously in the same case. So, in this particular case, you have a water density target sign towards the right of the screen. So, that is in yellow color. And towards the left, you got a hyper enhancing bowel wall. So, that is blue in color. Okay, so they occur in the same case at the same time. Again, both indicate the same thing, that it is acute inflammation or mesenteric ischemia. Then this target water density target sign in isolation could also be due to portal hypertension. Now coming to the cold sign, the comb sign as a clue to mesenteric ischemia is something very interesting and often misunderstood. So we have a bowel wall here which is showing a target sign. Okay, water density target sign. But also when we look at the mesentery, the vessels within the mesentery are very prominent and can be traced right up till the lumen of the external surface of the intestinal wall. So that is what we call the comb sign. So there's a prominence of mesenteric vessels, and this is due to fatty infiltration into the mesentery and inflammation related vasodilation. It's not due to edema in the mesentery, because edema in the mesentery actually makes the mesentery less black in color. Okay. Uh, Now the thing is, as the background becomes more fatty, the dilated vessels become more prominent. So this usually indicates that there is vasodilation and there is a chronic inflammation causing fat metaplasia in that area. Therefore, this is much more prominent and easily witnessed in cases of chronic wall inflammation, like such as in Crohn's disease, rather than in acute mesenteric ischemia. Okay, so again, comb sign is not equal to mesenteric ischemia. So here we have a comb sign. The comb sign in this case is subtle, but the abdominal pain had started around 5 hours prior to imaging. So that indicates that, it's more likely to be due to mesenteric ischemia. Okay, so this is the comb sign, and these are the blood vessels as I've highlighted them. Now, coming to the third thing, that is pneumatosis intestinalis as a clue to mesenteric ischemia. Now, this is basically an extension of gas that is, or air that is there within the lumen of the intestine into the wall of the intestine. So this is what it looks like. You end up getting extension of the intraluminal air into the wall. In the presence of a high clinical pretest probability of mesenteric ischemia, this is actually a highly specific finding and indicates mesenteric ischemia, because this would not happen in case of inflammation. Okay, so the integrity of the mucosa would not be lost in case of inflammation in most situations, and even if it is lost, it will not be enough to cause necrosis of the muscularis or the submucosa itself, and therefore extension of the air into that area. Now, this can also, however, occur as an incidental finding, if that is when you have no expectation of there being any intestinal pathology in cases of systemic sclerosis, in which case it's called it's benign, quote unquote, benign pneumatosis intestinalis. It can happen with long-term glucocorticoid therapy, and it can happen with graft versus host disease, as well as post-chemotherapy patients. Okay, so these are the situations in which you incidentally get it. So again, systemic sclerosis and glucocorticoid therapy are things that I routinely am exposed to. Now, there is also the concept of differentiating pneumatosis from what is called pseudopneumatosis. Now, see, air can get trapped between the mucosa and the intestinal contents. So, in that situation, it looks like we don't know whether it is inside the wall or it is out, within the lumen of the intestine. So, in a mildly thickened, dilated ileal loop, as in these cases, air density is there all around the intestinal lumen. But importantly, it is there in both the dependent parts of the intestine, independent parts, as well as the non-dependent parts. Now the thing is, air rises being less dense than water, so you would not expect it to be there in the dependent parts of the intestine if the air was within the lumen. So therefore, the fact that it is within the dependent parts indicates that it's true pneumatosis intestinalis. Okay, so this case is the true pneumatosis intestinalis. Okay, now air density in pseudopneumatosis intestinal would go in the direction opposite to that of gravity, would be seen in the non-dependent part of the bowel wall. Okay, and again another thing is that once if this is within the wall of the intestine, it would start extending into the portal veins. So in this particular case, you can't really see that. But if once the air has entered the portal veins, that means that obviously it has extended from the lumen of the intestine into the submucosa and from there into the portal veins. So then that is definite pneumatosis intestinal. It is no longer, it is no longer pseudo. It is definite pneumatosis intestinal. Okay. So at the end of this, we can say that all three signs, that is mural stratification, particularly with water density, comb sign, and pneumatosis intestinal, are more characteristic of inflammation and it is less characteristic of mesenteric ischemia, unlike what is routinely said. Okay. Actually, pneumatosis intestinalis is more suggestive of mesenteric ischemia, but the other two are more suggestive of chronic inflammation. Okay, so if we have these target sign, comb sign, and pneumatosis intestinalis that are not specific to mesenteric ischemia, as in they can occur in other situations as well, what are the specific findings that indicate mesenteric ischemia? Okay, so we know already, and this is the first thing that I said, that non-enhancement of a part of the bowel wall as compared to the surrounding bowel wall indicates that the contrast is not going to that area. So that is definitely due to hypoperfusion of that bowel segment, which means it is mesenteric ischemia. Now, again, I said the length and distribution of mural thickening is also telling, although it is not specific, it can increase the likelihood of inflammation versus intestinal ischemia. Additionally, there are two findings that are highly specific. So if you see them, you know that the patient has got mesenteric ischemia. The first one is hepatic venous gas. Okay, that is air density within the veins of the hepatic veins. Uh, the second is a sequential wall change, that because the sequential wall changes that occur in intestinal ischemia are different from those that occur in Crohn's disease. So now talking about gas in the hepatic veins, this is highly specific for acute mesenteric ischemia, but it indicates likely that the patient is not going to survive. So you can't really depend on this clinically. So as you can see, there is air within the liver here, but it's mostly in the outer half of the liver. Okay, so it's within the outer half of the liver. So naturally, since the air again rises above water, uh, if it is in the portal, it is within the hepatic veins, the air is likely to go towards the periphery of the liver. Whereas if you're talking about pneumobilia, that is, there is air within the biliary apparatus is primarily located here in this area. So in that situation, you would get air primarily in the inner half of the liver. Okay, it's not really that easy to differentiate, but yeah, in pneumobilia, almost always the air would be here. So that indicates obviously the clinical presentation would be completely different. You would have a lot of abnormal liver enzymes and things like that. So it's a imaging differential, it's not really a clinical differential. But again, air within the hepatic veins uh, is highly suggestive of acute mesenteric ischemia, and it's probably indicates that the patient is not likely to survive. Okay. Now, the sequential changes in intestinal wall morphology on CT imaging are actually the most useful differentiating feature between neural ischemia and inflammatory bowel disease. However, the issue is that sequentially CT imaging would likely not be done. Okay, so again, clinically, what I find most useful is the distribution of the thickening and the length of the thickening. Then sometimes when the other three signs, that is the comb sign and the mural stratification and pneumatosis intestinalis are present, I use them. And then sometimes when there are different parts of the bowel wall showing different, degrees of progression, that can also help me differentiate. Okay. So the other So let's talk about the sequential changes that occur in Crohn's, that is the prototype of inflammatory bowel involvement, and acute mesenteric ischemia. So we have Crohn's disease and we have acute mesenteric ischemia. Now, progression of wall thickening. Now, in Crohn's disease, as the disease progresses, the wall thickening persists. Initially, there is early enhancement. Later, there is fibrosis, so there is delayed enhancement of the bowel wall. Okay. In acute mesenteric ischemia, the wall becomes progressively thinner because as the ischemia worsens, the tone within the smooth muscle within the wall decreases, and there is dilatation of the wall. And we usually say less than 3 millimeters is the cutoff for a thin wall, but this is in a distant bowel wall. Now, this again, eventually there would be necrosis of the mucosa and the submucosa, resulting in pneumatosis intestinalis. Okay, Crohn's disease would not progress to in pneumatosis intestinalis. Now, because in Crohn's disease the bowel wall is actually thickened, the risk of rupture is very low. Although the inflammation is transmural, so could extend into surrounding, it could fistulize into other epithelial tracts nearby, such as the rectum, the vagina, the vesicle, the liver, the bladder. I mean, the bowel, the urinary bladder. Now, in case of acute mesenteric ischemia, if uncorrected, it's likely to progress to full-fledged necrosis, and there would be you would end up getting pneumoperitoneum. And mesenteric changes, because the Crohn's disease is a very chronic process. The changes are often very prominent. Okay, so early lesions may not be concentric, and the inflammation may primarily be involving only the mesenteric border of the involved intestines. Now, however, mesenteric changes are variable in case of acute mesenteric ischemia and change as the severity of or increase as the severity of the ischemia worsens. So, mesenteric changes are much more prominent in cases of mesenteric vein thrombosis, which we'll discuss two lectures from now. While talking about portal vein thrombosis as an extension, but they are much more prominent, obviously, when there is mesenteric vein thrombosis as compared to arterial or small vessel ischemia. Okay, so these are the sequential changes. You might find these changes in different aspects of in different locations of the bowel, and when present in concomitantly with each other, they indicate there is ischemia or Crohn's disease. So now, where does this leave the one, people like me who are interested in diagnosing individual patients? Where does this leave us? So in case of situation, again, we've got our patients, clinical situations, that is situation 1 and 2. Now, in case of situation 1, we knew that we needed imaging to differentiate between acute mesenteric ischemia and small intestinal obstruction, but there was nothing very, very specific. Okay, so in case of situation 2, we knew that we just need to evaluate the patient for those specific causes. Now, in this particular case, we need to depend on imaging, and as I've discussed, imaging findings have some clear interpretations, but there is nothing that is pathognomic of acute mesenteric ischemia except for hepatic venous gas, which naturally it's too late by then, so there's no point in discussing that. Okay. Now, at finally, as we end, uh, both of these patients, these are CT scans from two different patients, and both of them have a history that is compatible with what was described in situation 1. Now, which one of these patients has Crohn's disease and who has acute mesenteric ischemia? So, uh, let's analyze. So you can see that there is very grossly dilated bowel here. There is some thickened bowel here in the right lower aspect of the intestine here. And actually, this is the ileum. So it is affecting the ileum. There is also involvement of some part of the ascending colon. So because there is long segment involvement of the of the ileum, we would think Crohn's disease is more likely than ischemia. Okay. Now, however, on this side, we have actually, this is the same patient that we discussed earlier. They have a jejunum that appears to be enhancing normally. There is involvement of the ileum, yes, but there is also involvement of distal jejunal loops, and there is very prominent, very long segment involvement of ileum and jejunum. So that would leave us with the possibility of mesenteric ischemia over other things. But again, in this situation, I cannot say that it is definitely mesenteric ischemia. Here, I would say that this is Crohn's more than mesenteric ischemia. Here, I would say Crohn's equal to mesenteric ischemia. Okay, so actually, there is a comb sign here, and again, the comb sign would make me think more towards towards Crohn's disease. However, this is actually a case of mesenteric ischemia. Okay, so as you can see, in the best of cases, you find it difficult to differentiate between the two. So, clinically, often the decision lies on involvement of extraintestinal manifestations, and in that situation, we treat accordingly. Now, either way, the treatment here would be steroids, pulse steroids, or high dose oral steroids. Uh, but this is important to differentiate because the prognostication of the patient and the evaluation of other disorders, coexistent disorders, would be different in each case. So, in this discussion, I have covered the following topics. We've reviewed the radiological anatomy of the GI tract on CT. We've described the imaging appearance of true intestinal obstruction. We've deduced the clinical situations in which a patient who is suspected to have an intestinal obstruction would require attention from internal medicine. We talked about the distribution of wall thickening to determine possibility of intestinal bowel inflammation and vasculitis as a cause of bowel wall thickening. We've talked about other findings that might suggest ischemia, but are not pathognomic of ischemia. That is mural stratification, comb sign, and pneumatosis intestinals, and we've understood exactly what they mean. So essentially, mural stratification and comb sign are more suggestive of inflammation than ischemia, but they can occur in both. And pneumatosis intestinal is suggestive of ischemia, but it can also occur in there is benign pneumatosis like we get in systemic sclerosis. Then finally, we'll talk about the sequential changes that help you differentiate Crohn's disease from acute mesenteric ischemia. So, as you can see, the final call on whether it is acute mesenteric ischemia or an inflammatory GI pathology often is made based on a combination of clinical presentation, so situation one, and the imaging findings, and often one says that Crohn's is more likely than ischemia, or ischemia is more likely than Crohn's or an inflammatory pathology, and we cannot really be 100% sure. Okay, so it's in fact uncommon that you are 100% sure that it is ischemia or the other. Okay, but obviously in a patient who's got lower limb, gravity dependent purpuric lesions, peripheral neuropathy, choroid positive, you didn't get this, you're thinking of vasculitis. Okay, so that brings us to the end of this particular discussion on the imaging of uh, in imaging role of imaging in the evaluation of patients who have suspected intestinal obstruction or acute mesenteric ischemia. So thank you for watching, and I'll see you in the next video when we'll be discussing um, and we'll talk about localized abdominal pain due to parenchymal organ distension, that is the liver, spleen, and renal distension.